I find that it's a very interesting thing about how we explore outcomes. And Dr. Barnett has taught me a lot in the last few years about how to go about evaluating my patients more comprehensively. And I think one of the issues could be to the patients adjust to their illness, right? They develop an adjustment. Even if their ADLs are not low or their impairments are not very minor, they come to a stage where they're happy where they are and they don't want to rock the boat and change the therapy. I had a patient like that the other day. I saw him 6 months ago. He hasn't had myasthenia so long. And I had put him on treatment 6 months ago. His impairment scales was the same, and the percent of normal was the same. And his past, like, was this acceptable? Was no. Yesterday, when we did everything, his percent of normal was the same. His impairment scales were the same, but the past had become yes. So he had adapted. How do you think this influences the way we study myasthenia and how we treat it? Are we falling into a placid acceptance of a subpar life that our patients may have? Should we accept that?
I mean, I don't think so, Dr. Bril. I think that we need to strive for better. We need to strive for minimal symptom expression or asymptomatic. I think from the patient perspective, right, they kind of adapt, they compensate, and they become complacent. But I think also from our standpoint, I mean, I think like the both of you and like many people that take care of patients with myasthenia, we're also taking care of people with really untreatable disorders. And I think that we get in this mindset that, well, the myasthenics are doing a little bit better than the patients with other diseases. That's good enough, when really we need to push the envelope ourselves and really, strive for minimal symptoms or asymptomatic state in our patients with myasthenia.
Yeah, I agree. I think it's both. Sometimes it's the patients who don't want to rock the boat. Sometimes it's ourselves. I think it also has to do with the limitations of current treatments that we've had. So when you have treatments that are very toxic, or someone who has not responded or has had major side effects to everything, it becomes increasingly hard to go up above when your options are limited. But once you have new treatments and options to explore, that I think should, both for patients and clinicians, make us more likely to strive for that. So I agree. I think what we've seen in recent years is that most patients are not doing that well. Even when you think they're doing well and you really ask patients, they're quite limited, even if they seem okay, right? Sometimes myasthenia is one of those invisible disabilities, because many patients don't look like they have myasthenia. They can walk down the street and they look fine, right? But they're not fine. They walk a few blocks and they get fatigued. They have to stop what they're doing. So I totally agree. I think we shouldn't be complacent, and we should go, and get that one-on-one patient perspective of what it is that we can help them with and improve.
So the other interesting case I had was a man in his early 60s. He's had a dramatic improvement with Imuran. He doesn't know he's got myasthenia, he says. But what he has developed is recurrent skin cancers after several years of treatment. And I'm loath to leave him. I said, you have got to change. You've got to come off. I'm going to try you on something else. I just can't continue to prescribe. He actually pled with me to leave him on Imuran. And his comment was, what? I would rather have 10 years at 90% rather than 30 years at 10%. So we have to take into account not that I left him on Imuran, I just, convinced him, but our patients' preferences are extremely important as well. And their judgment of their lives has to be considered, I think. What do you think? What would you have left him on Imuran, or would you have gone with me and made him stop?
I would not go against you, Dr. Bril. I totally agree with your decision. In fact, I think that the oral immunosuppressants have done a great job for many a patient. I have many patients who like your patient are asymptomatic, but I do worry about side effects. In fact, I had just published a case report of a patient who I had in basically minimal symptom expression on mycophenolate for many years, who developed CNS lymphoma related to this mycophenolate. So thankfully he's doing well, thanks to my colleagues in neuro-oncology, but now I'm a little scared. I realize it's a rare occurrence, but certainly it makes me a little gun shy. And I think that, you know, looking at future therapies that might be a little more kinder and gentler in terms of side effects, both short and long term, it really gives me pause.
I hope that the future holds anything and everything that I want it to hold. You know, I don't believe that myasthenia will shorten my life, and I hope that it doesn't drastically impact the quality of my life. You know, I do have fears over the rate at which I might get cancer due to the immunosuppressants that I take, and that is more likely probably to impact the quality or length of my life. But until then, we cross our fingers and listen to our doctors.
I'm happy to conclude this session unless you have any other closing remarks, Dr. Bril.
No, I would just like to thank my colleagues for excellent presentations. Thank you.
Thank you.
Thank you for coming.
Yes, thank you all for everything you've put into this. And from the CME Institute, we thank all of the participants as well as the faculty, and invite you to please complete your post-test and evaluations and seek your CME credit. Thank you.